Today, I'm just going to talk about delirium. And delirium, you probably have seen a million times over, but we're going to go over like some small details of delirium. You can also probably recognize delirium as altered mental status. So when your patient that you see every day is not their usual self, right? That's probably how I could identify it in layman's terms, what delirium is. We call it altered mental status, delirium. So some delirium stats here. We're in a nursing home. You got quite a lot of delirium in a nursing home, upwards of 60%. In the hospital, it's pretty up there, but you guys have it even worse here in the nursing home. And in the ICU, it's especially high. It's upwards of 80+% in the ICU. Why is delirium so important when you see your patient that you dress, eat, bathe, transfer, toilet, help assist to walk? Why is it so important? Because, and you notice that they're not doing well, they're not themselves. It's important because it's an independent risk factor for worsening dementia or the development of dementia, and it's an independent risk factor for death. That's why it's so important for you guys to identify what delirium is. And you probably have seen it plenty of times before. And it costs a lot of money. It costs close to $150 billion per year. But if you guys could identify it, maybe we don't have to transfer that patient. We could identify it quick. You could tell the nurse, and they could start the treatment immediately, or at least notify the doctor. They could start diagnostics, treat the patient, etc. And it all started with you. But there's a challenge to delirium. We may not know how to recognize delirium. I know when you think somebody's delirious, you could probably tell by just seeing it, but we don't know the true definition. And there's this extravagant definition that's updated here. But if I would describe delirium, it's a disturbance of consciousness, some sort of disturbance of consciousness from the person's baseline. And it affects attention and cognition, how you think. And it's abrupt, it just happens suddenly, and it fluctuates in its course. So you guys have a shift, right? From, is it 11 to 3 or 8 to 3? 7:30 to 3?
Yeah. 7 to 3.
7 to 3. So it may fluctuate, during your shift, and then the next shift, that patient might have a different face to them. Okay, so it's abrupt, it fluctuates in its course, and most importantly, there's an underlying condition associated with it. Some underlying condition, okay? And that underlying condition is very life-threatening, okay? So that's why it's so important to identify. This is the more extravagant definition. We don't have to go into that. 95% of cases of delirium are missed. 95%. Probably the person in this room that's most likely to miss delirium is me. Because I come in, maybe I'll come in, a physician will come in every month, every other month, and we don't know the patient. We just say, oh, how are you doing? Your labs look great. We'll see you next time. And then sometimes we don't bother talking to you guys. And you guys know all the details. How long could delirium last? Okay, this is how long we can miss delirium for. So it could last from hours to days to weeks and upwards to months. So we may have missed delirium upwards to months. Fluctuation. So like I told you, in one shift, it could be one type of person, and they may change to another. They may be completely lucid, and then they may be delirious again. So nurses and CNAs have often been the sentinel people to identify delirium. So it's very important. We used to have paper charts, and we would read the paper charts. That Mr. Smith is not doing so well. He usually plays bingo, and now he's in bed just staring into space. So the importance of recognizing delirium. Hi, how are you? There's an underlying medical cause. Okay, delirium has significant morbidity and mortality associated with delirium, right? It can be a harbinger to death, meaning that it is a predictor of death, a tenfold increased risk of death. And then there's a 3 to 5 increased risk of nosocomial complications. Nosocomial means something bad happening or a complication that happens in a healthcare setting, like the nursing home. So just imagine you are delirious. Imagine you have delirium. Maybe you're not when you're delirious, you probably can't swallow correctly. So all that secretion can go into the wrong pipes and you could get aspiration pneumonia, number one. You might not feel the sensation of pain and pressure, so you're not turning. So if a person's in bed for a long period of time, they don't turn. And what could happen there? They could develop a pressure ulcer, right? It's associated with longer hospital stays. I told you it costs a lot of money when they go to the hospital. And then their functional recovery is a lot worse. They have sustained loss of function. So they're more dependent on now the CNAs. They're more dependent on the CNAs. You know the basic ADLs. Of course, you guys know that very well. So dressing, eating, bathing, toileting, transferring. I remember it as DET, D-E-B-T. Dressing, eating, bathing, toileting, transferring, and walking. And the instrumental ones are the people in the community, right? The people in the community that could live in a community. Rather than feeding oneself, they could prepare their own food and eat. So that keeps people in the community. But with delirium, all these things get compromised. So probably in the community, they may need somebody equivalent to you, like a home health aide. But here, CNAs. Okay, here's challenge number 2. We may not know the patient. So a common problem with nurses, I always hear on the phone, how's this patient usually when I ask them? How is Mr. Smith usually when, in this day? I don't know, I just came on board. I'm in a different part of the nursing station. I usually work in the other unit and I don't know this person very well. So that's a common problem, okay? And it's no fault to you, obviously, because you've been moved from shift to shift. But hopefully, how can we mitigate that? Hopefully we could have a familiar nurse that knows the person for a long period of time. You have a familiar certified nursing assistant. I think the certified nursing assistants are always there around the station. They don't move you so much because they want you familiar with the patients, or I should say the residents. The residents, they're not patients.
No, yes.
Right, they are residents
Yes.
here. Okay, and then access to people familiar with the patient, such as family. Family's always helpful. So some tip-offs for delirium. They may not remember instructions. So you maybe change their bed and, let me just go back. They may not remember instructions. They may ask for the directions and instructions over and over again. Okay, so that's one thing. They may not remember you guys doing all your blessed things that you do, changing, helping them toilet and changing their bedding. And, they might say that nothing is happening here, and when in fact it actually is happening. They're disoriented. They're agitated. They may become agitated as a result of disorientation and confusion, and that's a bad thing, especially in a hospital. So they may think that they're at home, but they're actually in a hospital, and then all these people coming are intruders. Here comes the CNAs and nurses. These are not CNAs and nurses. Who are these people? They're trying to break into my house. So that comes out with a bad outcome. They might be pulling on their tubing. They might need IV antibiotics for their underlying condition, and they pull that. So that's a problem. It's not only treating the underlying condition, how do we treat their behavior too? Okay? So that's somebody who's agitated, pulling and moving. You might have seen the opposite of that. You might have seen somebody who's withdrawn and apathetic, just in bed, listless, staring into space. That can happen as well. Okay? Their sleep might be compromised. So now they're sleeping in the middle of the day, or they're up late at night, and that comes with bad outcomes, right? Now they're walking about in the middle of the night, they trip and fall, they pull on their tubes, bad. Or they could be perceptual disturbances. They might be seeing things. There might be auditory hallucinations, they hear things. It's okay to ask those questions. Even though they're delirious, treat them like, are you hearing things? Are you seeing things? It's okay to orient them. There's different subtypes. So all those things I was talking about, that agitated person that's yelling and screaming and delusional, maybe throwing things at you, that's the hyperactive subtype of delirium, okay? What do you think? That somebody who's not familiar with that patient, it might be hyperactive delirium, but it might be somebody with a mood disorder, schizophrenia, schizoaffective disorder, bipolar disorder. That could mimic delirium, and vice versa. I'll tell you the other types. The other type is also called hypoactive delirium. Hypoactive delirium is also called quiet delirium. This person right here that's just staring into space, not participating in activities. What do you think that's mistaken for? Maybe somebody who is,
Depression?
Depression. Did you say depression? Yes, depression. Number one mistaken for depression. So somebody like myself, I've never met such and such resident in a certain room, and I just look at them. How you doing, sir? You're doing okay? Okay. I leave. But you guys know better. Matter of fact, there's this old 1995 study that showed that 42% of patients referred to psychiatric consultation. You guys get psychiatric specialists that come through here. 42% of them were mistaken for depression, but they were actually delirious. Okay? I still haven't told you what the causes of delirium are. And then there's a mixed type. Remember I told you it fluctuates? So it's mixed. It's hypoactive, quiet delirium, and hyperactive. That's probably the most common type. You probably will see. I bet you every single one in this room has seen this. I'm sure. Here's another challenge. I don't know what challenge number we're on, maybe 3 or 4. But what happens when delirium, you have somebody who has dementia, like an Alzheimer's dementia, but they also have delirium. It's not the same thing. Dementia and delirium, are not the same thing. And somebody who has that has delirium superimposed over dementia is twice the risk of mortality, twice the risk of death in a year versus just delirium alone. What do you think that is? Because maybe we don't recognize delirium, and then we let it linger on and on and on and on. Okay, so it's very important. When you think of dementia, dementia is this one umbrella of somebody who has poor memory and cognitive impairment, and is, what would you think of the one dementia example? What do you have here? Alzheimer's dementia? Yeah, I would think of Alzheimer's dementia. Alzheimer's? Right, so Alzheimer's is some chronic thing that is permanent. We don't know, we don't have any medications for Alzheimer's dementia that really reverses it. It's completely irreversible. Right now, at least in 2023, it's an irreversible thing. Okay, it's permanent.
For delirium?
But for delirium, it's something different. Let me give you an example of a cause of delirium, and I'll go over the whole thing. A urinary tract infection could cause delirium. So that's a reversible cause. So there's an underlying reversible cause in delirium. There's no underlying reversible cause in dementia or in Alzheimer's dementia. It's like brain plaquing and neurofibrillary tangles. So, and know that delirium waxes and wanes. So it's acute and it fluctuates. It can happen suddenly. It can last a long time. Dementia, it's just this permanent thing. Perhaps in your later shifts, you'll see in dementia, you'll have somebody that's more sundowning. So they're more alert in the day, and then they get more, their nerves get really tired, and they get a bit confused. Okay, some screening tools. Do you guys know what the minimum data set here is? Minimum data set, I think you have it in some of the charts. And they're tools, they're practical tools for nursing home residents. This one is the memory test, the MOCA test you've probably heard of, which is the Montreal Cognitive Assessment Test or the Mini Mental State Exam. That's not the best test for delirium. That test really for your memory, probably when you go to the doctor and they tell you, where are you? What year are we in? Can you draw something for me? This is more for memory, right? But there's something a little bit better that maybe you could find in those charts called the minimum data set, and that is called the CAM test. This is the CAM test. So this is how you identify delirium. Like I told you, part of the definition, it's acute and it fluctuates, waxes and wanes. There's distractibility, right? I'll tell you what that is. There's disorganized thinking and there's altered mental status. You must have these first two things: acute onset and fluctuates, and having inattention. Once you get those two, you could have either 3 or 4, disorganized thinking or altered mental status. So, like I told you, it's acute and it fluctuates. Here's attention. So, when you're talking to Mr. Smith, let's say, is he easily distractible? Or when you're trying to explain something to him, is he following your commands? See, when he's not doing that, perhaps he's being inattentive. So that could be a little sentinel sign. He's out of touch. So they must have those first two things. Alert the nurse if there's something wrong. Disorganized thinking. Are they rambling? Are they unclear? Are they illogical? And you know that they've been fine before. Altered mental status. Now, altered level of consciousness could be very different. I told you the different types of delirium. You could have somebody who's very tired and sleeping, or you could have somebody who's very agitated and throwing things. So it's a big rainbow of things, big spectrum of things. Okay? Who's at risk of getting delirium in your resident population? Older people, obviously, especially 75 and above. Males. Somebody who has dementia has a tendency to have delirium more so. People who are on a lot of medications. You know, like what the average amount of medications are here in the long-term care facility? Probably roughly 9 medications. So imagine you take 9 medications every day. Something's going to mix wrong. You're going to have a drug-to-drug interaction, and you could get delirium because of some overdose, or the level's too high, and your sugar is too low, your blood pressure gets too low. These are drug-to-drug interactions. So, right? Somebody who has alcohol abuse and hospitalized patients, especially cancer patients, HIV patients, and post-operative patients, especially the surgeries, the 2 surgeries that are high incidence of developing delirium is open heart surgery and hip surgery. Open heart surgery and hip surgery. Those are the 2 that are really high. Okay? There we go. It's usually not from the anesthesia. It's usually from, some emergent procedure like a hip and open heart. So it's very important. Pain can cause agitation. I mean, have we all been in a bad mood because we've had back pain or something? So just imagine somebody who has dementia, who can't explain to you, I have back pain or I have shoulder pain. They're gonna, how do they manifest that? They get agitated. So important strategy for me to write is to have scheduled medications rather than PRN. You know what PRN means? As needed? Mm-hmm. Yeah. So hopefully, after a major operation or somebody's in chronic pain, we should have scheduled medications rather than just having a PRN. This pathophysiology is so complicated. Even I get dizzy looking at this thing. However, all this stuff is happening, and at the end, there's a surge with a delirious patient. There's a surge in dopamine. And dopamine makes people agitated, a high surge in dopamine. So, how do we treat delirium? We got to block dopamine. So, part of doing that is giving them medications that block dopamine for a small period of time. Okay, that's to treat the symptom, but does that treat the underlying cause? It just stops the behavior, but it doesn't stop with, treating the urinary tract infection, for example. It's not going to take care of that. Very important to find out. Here's another challenge. Very important to find out the cause of delirium and do it quick. Okay? More than half of elderly patients have 2 or more causes of delirium. Some underlying cause, 2 or more. It's not just one thing. Life is not just A and B. It could be A and B, right? It could be many things. So let's talk about the causes of delirium. And guess what? Delirium spells out, the causes spell out the word delirium. The causes will spell out the word delirium. So remember I told you about the drug-to-drug interactions? So drugs are highly associated with delirium. D for drugs, okay? And there's these special drugs that on our list, a list of drugs like Benadryl. You know when you go to CVS, Walmart, Walgreens, have you ever seen Tylenol PM, Advil PM? Well, that PM is Benadryl in there. So for elderly people, that's a terrible medication. Why? It has something called anticholinergic effects. It could cause them to have delirium. It could cause them to not be able to pee, to lower their blood pressure, to have tachycardia. I don't know why they still sell that medication to older people. There should be a warning about that. But be careful. Those are sleep aids. Tylenol PM is a sleep aid. So all these are medications that we have to be careful about, that are anticholinergic, we call them. Electrolytes, so somebody who has a high sodium or low sodium or high calcium or a low sugar, those are electrolytes that cause delirium. Obviously, if your sugar is 40, you're going to be delirious. Any one of us would have that. L for lack of drugs, so drug withdrawal. I told you about a lot of medications and drug-to-drug interactions. There's drug withdrawal. Okay, and drug withdrawal can cause backfiring and altered mental status. I for infection. I told you urinary tract infections especially, and pneumonias, especially here. Pneumonias and urinary tract infection. R is for retention. Some people have a very sleepy bladder. Some people here maybe have, some residents here may have Foley's or a suprapubic catheter perhaps. Well, maybe it's because they have a sleepy bladder and it's caused by urinary retention. And urinary retention is a cause of delirium. As a matter of fact, in the old times, they used to call urinary retention cysto, meaning bladder, cerebral syndrome. Bladder, brain syndrome, cystocerebral syndrome. I, again, for intracranial, anything in the head. Intracranial means in the head, so a bleed in the head, anything, a bleed, a big tumor, etc., a stroke can cause altered mental status. U for uremia, meaning dehydration. And then M, heart, myocardial and pulmonary. So imagine somebody's gasping for air, that can make you delirious as well. So I told you about drugs, withdrawal, the workup. Please, all the CNAs, if you see something wrong, tell the nurse. Can you maybe call the doctor because there's something wrong with Mr. Such and Such in room 1 something. Always have the nurse. We have to do the vitals. We have to check the oxygen. Remember, low oxygen can cause delirium. Low sugar could cause delirium. High sugar could cause delirium, right? So it would be embarrassing if somebody's sugar was 30, but you took them to the hospital for a CT scan of the brain. We missed the obvious. Always do a medication review. Remember the drugs. There's a lot. You'll be surprised about the drug-to-drug interactions. And then we have to check the bladder. If there's urinary retention, check the abdomen if there's abdominal pain, and always ask about pain because pain will make all of us irritated. And then they can do labs. Treatment. Always treat the underlying cause. That's the most important thing because that underlying cause could mean death. Right? How can we make some small interventions? Hopefully we can reorient these people, have a close family friend around the area, have a clock to orient them, have a calendar to orient them. Optimize the senses. If they have hearing aids, put their hearing aids on. If they have glasses, put glasses on. You guys have a beautiful model here. What do you call it? The greenhouse model. So you want to make it look as homely as possible, have good, not a lot of sound, not a lot of stimulation, not a lot of lighting, and nice temperature as well. Physical restraints are usually a no-no in a nursing home, right? Because it's an independent risk factor for worsening delirium. You put straps on, just imagine you're delirious. And now you don't know where you are, and somebody's putting an anchor, is wrapping you around like a rope, and it's holding you down. You're gonna feel better about that? It's gonna be much worse. So unless it's absolutely necessary, you can't really do that in the hospital. Usually it's for the hospital type of people. Remember I told you about dopamine and blocking dopamine? So for the time being, a doctor could prescribe something for the dopamine surge, the anti-dopaminergic meds. You've probably heard of Haldol, quetiapine, Seroquel, Risperdal, all those they're not good medications because they cause a lot of bad things. They have implications on the heart. You have an increased risk of falls. You know, some of your patients or some of your residents that have those medications, they tend to fall more. Higher risk of aspiration pneumonia. That doesn't sound good. Higher risk of stroke, higher risk of death with these medications. So we have to use them at a small period of time and just take it off when it's time to take it off. Treat the underlying cause, That's the most important thing. But the problem is sometimes when they have an IV going, because they're dehydrated and they pull on it, well, you got to do something about it. So the more important thing, rather than getting a restraint, is to have a one-to-one sitter. If there's a luxury of that. I don't know if there is. Okay, there's more medications, like sedating medications. Again, that's just symptom control. Always talk about, ask them about pain. Are you in pain? Do you have back pain? Maybe we could give you Tylenol, ice, etc. Other issues, and my last slide. Caregivers like yourself, you might have a close tie with the people that you take care of. They're 12 times more likely to develop anxiety disorders, especially the family members, than caregivers of non-delirious residents and patients. So they experience a double bereavement. They're at higher risk of death, so they experience that double bereavement, the loss of connection that they used to have with the resident and the actual death. So that's called double bereavement.